Hello everyone. Today we will be discussing about dilatation and curettage. This is a series of operative lectures describing the surgeries in detail. So it is dilatation and curettage, but we will be also be discussing dilatation and evacuation. There are two things. If the uterus has something inside, mainly the retained products of conception in cases of abortion, then it is called as evacuation, and if it is done for some gynecological purpose, then it is curettage, but the procedure is mostly the same. So this is an operative procedure, important. We don't generally do it on OPD basis. It is an operative procedure whereby dilatation of the cervical canal followed by uterine curettage is done. So this is important from your viva point of view, that this is the uterus and this is the cervical canal. So this is dilated and this is evacuated or curetted out. This is the most common gynecological operation done. So we were discussing about hysterectomies. Now it is the most common and most less duration surgery performed. Indications of DNC. What are the indications when we do these surgeries? This is for the purpose of writing, basically, that you writing in your exam or in your vivas, that it could be therapeutic or diagnostic. Why we are doing this? Infertility. In past days, we were doing it as a diagnostic procedure for infertility to check for luteal phase defect or the phase of the endometrium, but nowadays it is an obsolete procedure in case of infertility. Abnormal uterine bleeding, yes, definitely. If the patient is not responding or there is some endometrial problem that you are looking into the USG, then we are going for dilatation and curettage. But yes, nowadays in that cases also we are doing hysteroscopic guided procedures. That means we see and we take the biopsy out. It is not a blind procedure anymore. But for your exam point of view, this is a right indication. Pathological amenorrhea. That what does that mean? Physiological amenorrhea means either the patient has not attained menarche, or there is menopause, or she is pregnant. In these three cases, this is physiological amenorrhea. Then in those cases will not go. But pathologic amenorrhea, that means secondary amenorrhea, that the patient was earlier menstruating but now not. So you want to rule out either tuberculosis or any some other pathology. So to take that biopsy material to send for histopathological examination or any other examination, we can do a dilatation and curettage. Endometrial tuberculosis, as I just discussed. Endometrial carcinoma or postmenopausal bleeding. What does that mean? That once the cessation of menses is there for 1 year or more and then the patient has bleeding again, then earlier it was the gold standard investigation that you do a dilatation and curettage and send the thing for biopsy to see whether it is a case of carcinoma or not. But nowadays hysteroscopy guided biopsies has actually changed the scenario. It has replaced dilatation and curettage. Therapeutic incomplete abortion, DNE, what I was talking about, that in cases of incomplete abortion there are retained products of conception which lead to continuously bleeding. So to stop that bleeding, dilatation and evacuation was the gold standard, and now it is the gold standard now itself. Combined indication means both therapeutic as well as diagnostic. Endometrial polyp, DUBs, that is abnormal uterine bleeding, or endometrial hyperplasias, where you want to check that what is the cause, then you curate it vigorously. It can lead to diagnosis as well as therapeutic. But yes, nowadays the main indication of DNE is incomplete abortion. Otherwise, almost in every case, hysteroscopy has replaced DNCs. Now we will study the principal steps, that how do we perform the surgery. The patient is to empty the bladder prior the operation. This is very important. If you are discussing this in the front of your examiner, then you will have to say that empty the bladder, because if the bladder is full, so you cannot actually make out whether the uterus is antiflexed or retroflexed, so the whole surgery is difficult. The operation is generally done under general anesthesia, or sometimes diazepam is given, that is some sedative with paracervical block. What is paracervical block? That if the patient is in lithotomy position, right, and you are seeing the cervix after applying the speculum, so at 3 o'clock and 9 o'clock position you infiltrate lignocaine, that is the local anesthetic, to anesthetize the local pudendal nerves ganglions over there, right. The patient is placed in a lithotomy position, and once she is in lithotomy position, we do the painting with local antiseptic solution and drapes are placed. A bimanual examination is performed. This is very important. What is bimanual examination? I discussed in my gynecological examination. Your one hand is inside the vagina and one is on the abdomen, and you are trying to palpate what? The size of the uterus, whether it is antiflexed or retroflexed. What does that mean? This means that if the uterus is like this, antiflexed, so the direction of your instrument has to be like this, right? If it is retroflexed, then the direction has to be like this. If you are not following the physiological direction of the uterus, you may very easily perforate a uterus. Generally, all the gynecological instruments which are used vaginally, they have got a curve to fit into the flexion of the uterus. So, emptying the bladder and then performing a bimanual examination are very, very important. Now, the posterior vaginal speculum is introduced. As we know, before any gynecological procedure, you will introduce the speculum and then hold the anterior lip of the cervix with the help of either a tenaculum or a vulsellum. All the instruments we have discussed in our prior lecture. A uterine sound is introduced to confirm the position and note the length, uterocervical length. I have discussed in my instrument lecture how to see the uterocervical length. But this uterine sounding is generally done in gynecological cases, that is DNCs, and not in DNEs. In DNEs, actually the uterus is pregnant, right? It is a soft uterus. So we just don't want to mingle with the fundus. We don't want to poke anything on the fundus because a small pressure can easily perforate a pregnant uterus. Cervical canal is dilated with graduated dilators. What that mean? That means that we have a dilator in hand. Earlier we studied the Hagar's dilator, right? Hagar's dilator, they are available in different sizes. So it is like a curved instrument with blunt tip. You hold it in a pen holding position approximately 3 cm or below from the tip, and then rest your 3 fingers on the perineum of the patient and slowly go inside, because at this moment you can easily cause any false passage or injury to the fundus or anterior wall or whatever. So you just don't want to enter into the uterine cavity. Our idea is to dilate the cervical canal. So these 3 fingers on the perineum and this 3 cm will act as a guard so that you don't go straight inside. Our idea is to go from the external os up to the internal os and stop right there, because we don't want to dilate anything else. So this is the cervical canal. The dilator should stop here. It should not move further. So the tip of the finger should be placed at a distance of about 3 cm or slightly more than the length of the cervical canal from the tip of the instrument, and it acts as a guard. It stops you from going inside. The tip of the instrument should pass beyond the internal os, evidenced by the fact that it is grasped by it. You can feel that yes, we are through the cervical canal, and does not fall even when the support is withdrawn. That means you have put your dilator and just release it. It will not fall down. That means you are through and through the cervical canal. The tip of the dilator should be directed anteriorly or posteriorly according to the position of the uterus. This is very important. That's why we have done that bimanual examination. We don't want to perforate our uterus. And still, even after doing all that, the anterior uterine wall is the most common site of perforation, because if you are not according to the flexion of the uterus, for example, your uterus is antiflexed and you go like this, you will perforate, right? So when the dilator is introduced, the cervix is made steady by the traction of the vulsellum. This is important. The left hand is putting a pressure on the vulsellum and the cervix is steady, and now in a pen holding fashion you are going like this. After the desired dilatation, the uterine cavity is curetted. See, in cases of dilatation in curettage, where you're doing a diagnostic procedure and you just want a piece of endometrium for your diagnosis, the tip of the curette is the guide. As soon as you are able to dilate and then your tip of the curette is going inside, don't dilate more. But if you are going for dilatation and evacuation, then for example, it is a case of missed abortion, it is 8-week size uterus, then what do? So you dilate till 9 number of dilator, because you want your 8 number cannula to pass. The thumb rule is 8 weeks of pregnancy, 8 number cannula, plus 1 dilator, because the dilatation should be more and you have to rotate your cannula inside it, right. But in cases of DNCs, minimal dilatation, that only your curette can pass. But nowadays, if you are doing some Pipel's cannula in the OPD, then no dilatation is required, and with the newer very small diameter hysteroscopes, no dilatation is required. So there is something called as Pipel forceps, which we can do in OPDs. It is a plastic small forceps where you can put it inside the uterine cavity and take out a strip of endometrium. But when we are talking about DNC, then dilatation is itself a procedure. And cervix is the only thing which has got those pain sensations. Once you are through the cervix, in the uterus there is no pain sensation. So the dilatation is the most painful part of the procedure. So after the desired dilatation, the uterine cavity is curetted by a uterine curette. With these all instruments we have discussed in our DNC instruments lecture, either in a clockwise or anti-clockwise direction, starting from the fundus. This is important. Whatever gynecological procedure you are doing, whatever, go slowly, reach till the fundus, very slowly. You don't want to perforate the fundus. And then whatever procedure you are doing, if you are curetting, come back from the fundus. In every gynecological procedure, you go deep and then come back. Whenever you are applying a pressure, you are always coming back, whether it is hysteroscopic procedure, whether this is blind procedure. So go inside and then come back. That's why uterine sound is important in case of gynecological procedures, because you want to know that what is the exact length. You have not perforated and gone inside the peritoneal cavity. The curette should be gentle but thorough. Thorough means your all walls should be curetted. Vigorous curettage may cause damage to the basal layer of the endometrium and uterine muscle. So it is a gentle curette but thorough. If you are doing a very vigorous curettage, your patient may well end up into Asherman syndrome in future. Once you are done with it and there is no active bleeding from inside the uterus, the valcellum and the speculums are removed and the curetted material is preserved, mostly in a solution of formalin, and sent for histopathological examination. Now complications. Looking to it, it looks a very simple procedure, but it is a very tricky procedure. You have to be very meticulous about your pervaginal examination, the direction of the uterus and the dilators. You can create a complication anytime because it is a blind procedure. Injury to the cervix. You are holding the cervix very tightly, the anterior lip, and it bites through. Bleeding starts from the cervix. Uterine perforation. You are not meticulous with your dilator, or it is a difficult dilatation. You can very easily perforate either the anterior or the posterior wall, and if you go forcefully inside, then well fundus also. Hemorrhage may start at any given point from any place. And injury to the gut and infection. If you are not if you are passing your instrument deep inside and you are inside the peritoneal cavity, you can damage any intraperitoneal structure, mainly the gut, because the gut is a mobile structure which comes first when you are inside the peritoneal cavity. Remote complication. Those were the immediate complication that will happen there and then on the table. But once you are done with the procedure, remotely you may find some complications. What are they? Cervical incompetence. That means the cervix becomes loose. If you have done some forceful dilatation and there is damage to the cervical fibers, then in future the patient may end up into cervical incompetence and mid-trimester abortions can occur. Uterine synechia or Asherman syndrome, what I was talking about. What happens, you are you want to be very sure that you are doing a very good job and you are not gentle with the endometrium and you have curetted the basal layer also. So the anterior and posterior walls of the endometrium, they stick to each other, forming synechia, and the whole endometrial cavity is damaged. So these are the remote complications which can occur. Now how to manage these complications, this is very important. Up till now, till undergraduate level it is okay, but if you are appearing for your postgraduate examination, you should know how to manage that injury which has happened there and then on the table. Injury to the cervix. So the injury to the lip of the cervix is caused either by a valcellum bite or a dilator has went wrong, so there is a total tear. The bleeding from the valsalum site is usually slight and it stops by pressure. You keep a gauze piece, give some pressure, it stops. But if does not, you can take a suture, hemostatic suture. But a tear is a very problematic thing. If you have torn something because of your forceful dilatation, then first do pressure. Whatever uterine bleeding, uterus is a very friendly organ. It manages itself, but you have to give pressure. If the pressure is not working and the hemorrhage is really brisk, so you must have damaged some of the artery. As we know that from the anterior branch of the internal iliac artery at the level of the isthmus, the uterine artery rises and there is a descending cervical branch also. So if any of the vessel is damaged, then what do? Either you pass deep hemostatic sutures like this, vaginally, blind sutures, deep hemostatic sutures, sometimes they control the bleeding. Or if it has gone up, then immediately you will have to perform a laparotomy, open up the abdomen and suture that torn vessel. So be very careful. A small procedure can turn up into a laparotomy also. Uterine perforation. We have to be very skillfully managing this uterine perforation. Uterus is perforated either by a uterine sound or dilator or curette in cases of DNCs, and in DNE even your cannula can go inside the peritoneal cavity. The perforation is more common in pregnant, as I was talking, because pregnant uterus is very soft and it give ways very easily. What happens? How do you know? You are performing the procedure and what happens? There is sudden loss of resistance. You put something inside and oh, it has gone inside. Your uterocervical length was only this much and your instrument is going deep inside. So sudden loss of resistance, passage of the instrument more than the length of the cavity, undue mobility of the instrument. You can go like this everywhere. So you are in an open space. And then in some cases, if you are through some vessel, then torrential vaginal bleeding can ensue. How do we manage perforations? Now you want to know what was your why were you doing this surgery? If it was a non-pregnant uterus, non-infective, non-malignant, that you have not spread any infection inside the peritoneal cavity, then you can manage it conservatively also. Small perforations, very important, every word is important. It should be small, it should be caused by either a sound or a dilator. Mind it, and no suction cannula. If your suction cannula was inside and you were doing suction at that time, then it was like it was problem. But if it was already sound or dilator, that too small, less than 8 number, then you can go for this thing. Watch the vital signs, monitor it, because as I told, uterus is a very friendly organ, it heals by itself. So administer antibiotics, discharge the patient after 24 to 48 hours. Important. So you are giving antibiotics, you are seeing the vital signs. What are you seeing? Abdomen is soft, pulse, BP, everything is normal. So in cases of small perforation caused by sound and dilator, you can go for conservative management. But if it was a large perforation or by a suction cannula, you have done some sort of a suction or there is hemorrhage, you will have to go for immediate things. First of all, laparoscopy. Put a laparoscope and see what has happened, right? So laparoscopy can be performed in all cases at the earliest. If the gut was injured and anything else was injured, go for a laparotomy or a laparoscopic repair of that rent, whatever you have created. Uterus, as far as uterus is there, if it has healed, it is okay, or you repair the rent, or sometimes in cases of torrential bleeding or major perforations, hysterectomy may also be warranted. Associated gut injuries to be looked for and if found to be tackled accordingly. So if you are not meticulous and there was perforation, especially with a suction cannula, and you keep on suctioning, many times major gut injuries have happened. Now I will be talking about dilatation and evacuation. I have already finished dilatation and curettage. All other procedures, complications, everything is same. But in evacuation you need to take things out, so you have to put a suction cannula. So here the anterior lip is stabilized with a valsellum and we have put the cannula inside. It passes just beyond the internal os. Here important is we don't want to go till the fundus. Just beyond the internal os you go and just turn on the suction. It will suction out everything. So of the same size as that of the uterus we take the cannula, 8 weeks pregnancy, 8 number cannula. Tip is passed just beyond the internal os. Important, what happens in a cases of vesicular mole? In vesicular mole generally the uterine size is huge, 14 weeks, 16 weeks, 20 weeks. What do? You don't have 18 weeks cannula, what do you do? So the important thing is that the size depends on what we want to suction out. In cases of pregnancy, there are parts of the embryo which we want to take out or placenta. But in the cases of vesicular mole, there is no embryo. There are small grape-like structures. So any cannula 10 weeks or 12 weeks will work because what we want to take out are small grape-like structures and not anything else. So this is a very important viva question. Examiners do ask that you have got a V mole, 20 weeks pregnant uterine size, what will you do? Sir, I will insert a 10 number cannula or a 12 week number cannula. The things will come out. Once you are through inside, then only the rotatory movements we do. Initially the size was this, we are doing rotation at this point because in cannula what I have shown, we have holes here and here. So you need to rotate because the vacuum should be done with every direction. And once the uterus is small, the things go on passing through the cannula. Last exam question is that how do you know that your procedure of dilatation and evacuation is complete? So the end point is that your cannula becomes a gripping sensation come. The cervix which was being dilated and soft now starts becoming tighter and tighter and it grips your instrument. You have difficulty in rotating. Grating sensation in curette or in the this movement of the cannula, you feel that you are grating at something which is firm and now it is not that soft. No active bleeding coming out from the os now because earlier in cases of incomplete abortion there was active bleeding. Now there is no active bleeding because we have taken out all the products of conception and no further material is coming out in the suction tube. There is a suction tube connected to your cannula. So till there are products of conception you can see those things passing through the tube. But once there is nothing coming, instead small air bubbles are coming. Then you find that yes, your procedure is complete. So these 4 things, gripping, grating, no active bleeding and no further material in the tube. You know that you are through your procedure. So I hope I am clear with the procedures of both dilatation and evacuation and dilatation and curettage. Thank you.